Welcome to this explainer. Today, we're tackling a massive, highly testable topic. We're going to break down those dense, word-for-word textbook notes on candidiasis, literally page by page. Why? So you can perfectly structure and absolutely crush that crucial 10-mark RGUH's exam question. If you're looking for the ultimate blueprint to ace this essay and grasp the concepts perfectly, you're in exactly the right place. Let's get into it. To do this, we'll use a 5-section roadmap, the exact structure you need to reproduce on your exam paper to score full marks. We're looking at 1. Introduction and causative organism, 2. Etiology and immunopathogenesis, 3. Classifying oral candidiasis, 4. Primary and secondary features, and finally, 5. Histopathology and treatment. Let's kick things off with Section 1, Introduction and Causative Organism, the fungal invader. Okay, so at its core, Candidiasis is just one of the most common opportunistic fungal infections out there. You'll also see it called candidosis, mononeliasis, or simply thrush. But here's a pro tip. There's this poetic French synonym, le muguet, which translates to lily of the valley. Dropping that term right in your introduction, that is a brilliant way to impress your examiner, especially if you're an Aviva. Now we have to identify the culprit. There are several species like Candida tropicalis, paracillosis, and cruce, but Candida albicans is by far the most common. And here's a really handy memory trick for the exam. Use the rule of threes. You need to memorize the 3 structural forms this normally peaceful commensal fungus takes when it decides to turn pathogenic. It exists as pseudohyphae, yeast, and cometospores. Jot those 3 down and boom, you've secured your introduction marks. Moving right along to Section 2, Etiology and Immunopathogenesis, setting the stage. Remember, Candida is strictly opportunistic. It literally just waits for the host's defenses to drop. So to get those full marks, you've got to list specific debilitating risk factors. We're talking about acute and chronic diseases, think TB, diabetes, and anemia. Endocrine issues are a big deal too, like myxedema and Addison's disease, along with severe immunodeficiencies like AIDS. Also, don't forget nutritional deficiencies, specifically iron, vitamin A, and B6. And finally, keep in mind that it heavily affects neonates, the elderly, and patients on broad-spectrum antibiotics. You need to explain why the infection takes hold in the first place, and this targeted list is exactly how you do it. Now let's break down the immunopathogenesis sequentially. Under normal conditions, your salivary IgA blocks Candida from adhering to mucosal cells. If the fungus somehow gets past that, T cells and neutrophils step in. Following fungal penetration, these cells use phagocytic and candidicidal activities involving myeloperoxidase to clear things up. But the critical takeaway here, when a patient has those predisposition factors we just talked about, this entire defensive sequence, from the IgA to the T cells to the phagocytosis, just completely breaks down. All right, Section 3. Classifying oral candidiasis, the structural map. Honestly, I cannot stress this enough. Categorical chunking is your best friend here. This is the Samurani-Eke 1991 classification modified by Axel in 1997, and reproducing this exact framework is the absolute secret to locking in high marks. You divide it into primary oral candidiasis and secondary oral candidiasis. Under primary, you've got acute forms, that's your pseudomembranous and erythematous, and then chronic forms like hyperplastic and nodular. Take a second to let that sink in. Then you have Candida-associated lesions, which include denturostomatitis, angular cheilitis, and median rhomboid glossitis. Finally, the secondary group covers systemic mucocutaneous candidiasis. Draw this table out exactly like this on exam day, and you are well on your way to a perfect 10. Next up is Section 4, Primary and Secondary Features, the clinical manifestations. You absolutely must contrast the 2 acute forms perfectly. Pseudomembranous candidiasis, or thrush, shows up as soft, white, slightly elevated plaques on the buccal mucosa or tongue. They look a lot like milk curds. The huge differentiator here is that this plaque wipes away with a gauze, leaving a red or relatively normal area behind. On the flip side, the erythematous form, often called antibiotic sore mouth, is consistently painful. These lesions are red and diffused because of increased vascularity and the loss of filiform papilla, usually popping up after a course of broad-spectrum antibiotics. Make sure you highlight this next chronic form in your notes because examiners love asking about it. Chronic hyperplastic candidiasis, also known as candidoleucoplakia, presents as firm, white, persistent plaques, usually on the lips, tongue, or cheek. And here's the kicker. Unlike thrush, these lesions do not wipe off. They look incredibly similar to leukoplakia, which is exactly why professors love to test you on the comparison. Now let's see how this builds into candidose-associated lesions. Take median rhomboid glossitis, for example. It's a central papillary atrophy of the tongue, basically a well-circumscribed red area with no filiform papillae right in the posterior midline. But here's where it gets really interesting. When this infected, depapillated area on the tongue constantly contacts the palate right above it, it actually transfers the fungal infection, creating an erythematous spot on the soft palate. Clinically, we call this the kissing lesion. Dropping the term kissing lesion in your essay will absolutely catch the examiner's eye. Finally, we arrive at Section 5, Histopathology and Treatment, from diagnosis to cure. This diagnostic flow is essential to commit to memory. First, you take fragments of the plaque material and smear it onto a microscope slide. Then, you macerate it with 20% potassium hydroxide, or KOH. Lastly, you examine it under a microscope to spot those typical hyphae. That 20% KOH smear is a mandatory detail. You simply cannot afford to leave it out of your answer. You want to finish your essay strong, right? List the specific cultures, stains, and drugs. For cultures, write down blood agar, cornmeal agar, and Sabaroth broth. For histology, state that yeast cells and hyphae in the epithelium are best visualized using specific stains, PAS, which is periodic acid Schiff, or methenamine silver. And for treatment, list your core antifungal agents. Nystatin suspensions held in contact with the oral lesions work wonders, alongside drugs like clotrimazole, amphotericin B, and miconazole. Hitting all these points totally proves your comprehensive clinical understanding. As you close your books today and review this blueprint, I want you to ponder the delicate balance between host and microbe. We know the predisposing factors, but what is the exact molecular trigger that flips the switch? What tells our immune system that this everyday, peaceful resident has suddenly become an invasive enemy? Keep that question in mind, and you'll never look at opportunistic pathogens or your pathology textbook the exact same way again. Thanks for joining me on this explainer, and good luck crushing that exam.